Well, thank you guys. Thank you all for joining us today. My name is Dr. Joji Kandam. I'm the Vice President of Healthcare Services for St. Jude Laboratories and the Vice President of Corporate Relations for its parent company, Bickham Healthcare. Now, the intent of today's genetics webinar is not only to educate and spread awareness, but also to discuss the options available to you as a provider or healthcare facility administrator. Now, when St. Jude Labs and PreCheck Health Diagnostics collaboration was cemented, we truly wanted to bring the care back into healthcare. And the best way to do this is by explaining some of the exciting new service lines we have to offer, especially in the field of genetic testing. Now, before we get started, I want to give a few introductions of some people who have helped make today's webinar possible. First and foremost, my fearless leader and the person who I have the pleasure of directly reporting to, Sonia Dovin. She's the co-founder at Bickham Healthcare and managing partner at St. Jude Labs, with over 20 years of revenue cycle management experience and almost 4 years of clinical diagnostics experience. Thank you, Sonia, for joining us. Francis Pitoloni, I know Francis is traveling. He's the managing partner of Miami, Florida-based PreCheck Health Diagnostics. Thank you, Francis, for joining us. And with Francis, I believe Frank Gillen is also with him, who's the president of PreCheck Health Diagnostics. Ahmed Alaklini is the CEO of DNA Visit, and who previously worked for 10 years at Thermo Fisher. He managed various genomic product lines and verticals, including pharmacogenomics, inherited, and infectious disease. And last but not least, I would like to introduce our amazing host for today's webinar, Heather Wetzel. Heather is the Senior Genetic Counseling Director at DNA Visit, where she leads the genetic counseling service and regularly counsels patients in the areas of pharmacogenomics, cancer, cardiovascular health, proactive health, and direct-to-consumer genetics. She received her master's degree in genetic counseling from Northwestern University in 2006 and currently works remotely out of Raleigh, North Carolina. Now, prior to her time in North Carolina, she lived and worked in the greatest city that I know personally, Chicago, and San Francisco, both as a clinical genetic counselor in cancer, pediatrics, and reproductive medicine, as well as a clinical liaison and operations manager at various genomic and telehealth companies. Now, without further ado, let's dive into the exciting world of genetics and explore the new service lines that St. Jude Labs and PreCheck Health Diagnostics have to offer.
Thanks so much for the introduction. Really appreciate it. And I'm going to start the actual slideshow here just to broaden the screen a little bit. But yeah, so the purpose of this webinar is really just to provide some background information about some of the test offerings and education about when these tests might be appropriate, what to look for when considering offering these tests, and really, most importantly, what are the benefits to patients undergoing these genetic tests as well as their family members. And so what I'm going to do is try to focus most on two of these tests, because as we start going through it, you'll sort of see a theme as we're talking about kind of who's appropriate for genetic testing and things like that. So I think if we stick to talking about cancer predisposition testing and immunodeficiency testing, those are going to be the areas where I spend the most time, and have a couple of slides about the other test offerings as well. The endocrine or diabetes and obesity test, thyroid disease testing, and then adult neurology. So just want you guys to have access to some information about those tests as well. I do have some information hidden in the slide deck too. So if you guys decide to share the slide deck or slides with anyone, there's more educational information about each one of those tests. And I'll show some examples of some flyers that we have as well about each of these tests. So we've got nice handouts that's sort of like a cheat sheet for each of these areas as well. So we'll talk about that at the end. So just to sort of kick off, one of the, I would say, more popular genetic tests that's been around for many, many years, carrier testing or genetic testing panels for cancer predisposition. And, these are, very frequently ordered tests. And like I said, even back when I was a clinical genetic counselor a long, long time ago, this was an area that I worked in back when we were just starting to test for 2 genes. So this is an area that's changed quite a bit. But I think the sort of ultimate sort of, what I call cancer genetics 101, that sort of is the same concept here. and that, really when we're thinking about people who have an inherited predisposition to develop cancer, it really is a very small subset of the population who were affected by cancer or who have family histories of cancer. So I think that's always important to point out that, we overall expect the vast majority of people who undergo genetic testing to have negative or inconclusive results. Only a small subset of people, approximately 5 to 10% of all cancers themselves, are associated with an inherited genetic mutation. Unfortunately, those genetic mutations come with a relatively significant increased cancer risk, not just for one cancer, but sometimes for multiple cancers in that same person. So those are obviously people that are very important to identify, because the cancer screening and cancer prevention recommendations are aimed at really trying to minimize those cancer risks if possible. As you see here, most people, in fact, 70 to 80% of cancers occur sporadically. They don't have a single genetic mutation that's causing those cancers that they're inheriting from say a mother or a father. There's a small subset, approximately 15% of cancers, that we sort of think of as familial. Maybe there's more cancer than what we might expect in a family. Those are probably due to a number of sort of common, what we call common low impact genetic variants, but also interactions with environmental factors or other non-genetic factors. Obviously, those come with some increased risk in an individual, but generally not to the level of what we'd see if there was an inherited genetic predisposition in that particular family. And again, as we talk about the other test offerings, the numbers aren't the same for every single test area, but really this sort of concept rings true for a lot of the disease areas we talk about in genetics, where certainly most of the time we're dealing with sporadic, non-inherited medical conditions, and the inherited risks that are identified on genetic testing tend to be a small subset of patients, but patients that have a drastic impact in terms of their medical management if they do have one of these genetic conditions. So small numbers, big impact in terms of the care guidelines. This is just an example of, in terms of cancer genetic testing, these are the sorts of things that we look for in terms of kind of a couple things. And I want to be careful in terms of how I say this, because as genetic counselors in 2024, we are huge advocates of people having genetic testing if they want genetic testing. When I'm talking about people who are good candidates for genetic testing, that means people who have a higher chance of a positive test result, as well as having a higher chance of their insurance company covering genetic testing. And so just keep that in mind as we're talking about who should have genetic testing, using that sort of frame of mind. Like I said, in genetics, as genetic counselors, we're large advocates of people having genetic testing, but sometimes it comes down to sort of how that's accepted. In the cancer setting, we kind of think about three areas in a person's personal and family history: multiple, young, and rare. And what you see here is just a few sort of examples of what we mean by all of those. Multiple, one common example would be breast ovarian cancer. Two or more individuals in that person's family who have what we see as related cancers that may be due to an underlying gene causing both of those cancers. Again, like breast and ovarian cancer, melanoma and pancreatic cancer sort of go together with a couple of these genes. Young, we think of early onset cancers as having a sort of higher risk of them being due to an underlying genetic predisposition. So examples of cancers that may occur at younger ages that have a higher chance of those genetic predisposition syndromes may be breast cancer under age 50, as an example. Rare, these are cancers that we don't see in every single family. Cancers that we think of as much less common in the general population, like ovarian cancer, breast cancer that occurs in a male, triple negative breast cancer we don't see as much as an estrogen positive breast cancer, for example. So, all of these are sort of think about them as red flags. They don't necessarily mean that a person will have an inherited genetic predisposition, but certainly an increased chance of finding something. And the more of those you see in a person's personal family history, the higher that sort of chance is that they may actually have something. I have another category here because, there certainly are other indications for genetic testing too. Obviously, if there's a pathogenic variant in a family member, that's sort of a shoe-in for genetic testing in that person. And then nowadays, we've started to see some other indications for germline cancer testing, such as positive testing from a direct-to-consumer test like 23andMe. We always want to confirm those test results and make sure it's not a false positive. So genetic testing is oftentimes recommended. And then some somatic testing, so some tumor testing, for example, can identify some inherited cancer risks. And again, another indication to do more germline testing. So in terms of benefits to patients themselves, obviously, it kind of depends on what sort of area they're coming from with regard to genetic testing. Are they having genetic testing because they have their own diagnosis of cancer? Or are they trying to be more proactive because they have a family history of cancer? There's benefits to both groups of people having genetic testing. For people who've been diagnosed with cancer, some people say, well, they already have cancer, so what is the testing going to do? Well, it actually does a lot. It can sort of, in these cases, it can help inform surgical decisions. So sometimes it may be that deciding factor for a woman choosing a lumpectomy versus a bilateral mastectomy if she finds out she has a higher risk of getting breast cancer again due to, say, a BRCA1 mutation. Obviously, benefits and availability of non-surgical therapies like PARP inhibitors that have become more readily available over the years can give some information about prognosis. Some cancer germline variants are more associated with aggressive cancers versus non-aggressive cancers. Clinical trials becomes important in these situations as well. And as I've already mentioned, understanding risk for other cancers. Some of these genes have not just one cancer risk associated with them, but other cancer risks. And so it can impact screening for other cancers that they may not even be screening for or be aware of. And of course, the obvious benefit of helping family members understanding their risk for cancer. For people in sort of the other category who don't have a personal history but are concerned due to a family history, obviously a positive result would impact that individual's management and surveillance decisions with the ultimate goal of preventing them from getting cancer in the first place. But if we can't, detecting cancer at a much earlier, much more treatable stage. Of course, the same benefit of risk assessment for family members applies here too. And then in a number of individuals, a negative result can provide some reassurance. If that individual has a really comprehensive cancer panel with no identified variant, that can give them some reassurance about their cancer risks. So here I just have an example, and I'd like to include, something that's not BRCA1 or BRCA2 because I feel like we've all heard of those two genes before. This is a gene called CHEK2, CHEK2, and this is just a good example of a variant that's not quite as penetrant as BRCA1 and 2, but still really important in regard to cancer risks and cancer screening changes. So in this case of a person who has a CHEK2 variant, primarily affects women's cancer risk. Women have an elevated breast cancer risk, anywhere between 20 and 44%, depending on family history and sometimes the exact variant identified in that gene. Men may have an increased risk for prostate cancer. Still out there what exactly that increased risk is, but it's thought to be potentially increased. And both men and women have an increased risk for colon cancer in this gene. And again, 2 to 6% lifetime risk may not seem that high, but it's higher than the general population risk. And so also important because it does change their screening recommendations. So women who have CHEK2 variants generally are recommended to start mammograms the same time as everyone else at age 40, But in addition to mammograms, we recommend that they consider additional screening modalities such as an MRI with contrast. Oftentimes women are alternating both of those screens, so getting one of them every 6 months just to sort of double up on the screening. Women and men who have CHEK2 variants are also recommended to begin colonoscopy screening earlier than the general population. And rather than doing a colonoscopy every 10 years, they're recommended to have it every 5 years. And so it does impact cancer screening or surveillance for colon cancer for both men and women. So I covered more information here about cancer testing panels, and I'm going to sort of switch gears and talk about a second test offering, which is testing for immunodeficiency syndromes. And I think this is kind of a newer area, a newer type of genetic testing panel that's sort of, becoming a little bit more ordered nowadays. And so I wanted to use this one as sort of the next example and cover some background information in this area too. So the primary immunodeficiency syndromes, we've really learned a significant amount of sort of genetic information about these syndromes over the years. There's over 300 different forms of primary immunodeficiency disorders, or PIDs, as some people refer to them as. And like I said, within the last 10 years or so, it's really sort of blown up in terms of identifying genes that are causative of these PIDs. They're inherited in a few different ways. So the inheritance patterns can sometimes tell us whether or not there might be a family history or not. And so this is kind of one really important area where we don't always see a family history of an immunodeficiency syndrome, because you can see some of these inherited recessively. And recessive inheritance, we don't always have a family history because those conditions occur when both parents are unaffected carriers of a genetic condition. And so you don't see that sort of, multiple generation impact that you see with, say, autosomal dominant inheritance and sometimes X-linked inheritance as well. The gene panels for immunodeficiency syndromes are sort of gigantic compared to some other genetic testing panels. They oftentimes have, anywhere between 100 to 400. I've even seen larger than 400 genes on these test panels because there's so much clinical overlap and so many different types of these immune deficiency syndromes. Some of the bigger conditions that we see on these panels are going to be conditions such as severe combined immunodeficiency syndrome, or SCID, as well as combined immunodeficiency syndrome. Both of those result in dysfunction of T lymphocytes, B lymphocytes, and in some cases, natural killer cells as well. One of the differences is that SCID seems to be much more severe with an earlier onset. And so we do see, children impacted more by SCID, but both have pretty significant risks of sort of immune deficiency symptoms. So when we find those conditions, we're always concerned about whether there might be an inherited variant that's causing them or underlying them. Again, similarly, who should get tested? We sort of think about them similarly to some of the cancer panel sort of ideas here. Again, if there's a family history, obviously that would be an indication for genetic testing. Rare symptoms may be an indication for genetic testing. And early onset of symptoms would be an indication to consider genetic testing. So sort of, again, using that same sort of concept that we talked about with cancer genetic testing. And then again, some other examples specific to this area would of course be newborn screening, suggestive of severe combined immunodeficiency. These conditions are covered on some of the newborn screening tests. Multiple bacterial infections like sepsis, meningitis, cellulitis. Those are all areas where, with these sort of recurrent infections, immunodeficiency testing may be considered. And then again, any of these conditions that have been diagnosed in a family member would be indications to consider immunodeficiency syndrome testing. One area that's sort of interesting to me, just because, again, we've seen a number of these types of panels here at DNA Visit, is we seem to get a lot of test orders for individuals who have autoimmune conditions. And really, in those cases, we really don't expect that someone's going to have a positive result on a test like this, because the autoimmune diseases, like, say, rheumatoid arthritis, for example, tend to not have a single gene cause. And so those sorts of conditions really aren't the best sort of area for having this type of genetic testing, but we do see them quite a bit, because I think there's sort of the idea that maybe they have some sort of single gene condition that's caused that, but normally those are not inherited by single gene findings. So it's just sort of an interesting experience that we've had with some of the orders for this genetic testing. It really does sort of fit more with these sort of recurrent infections that really gives rise to a higher risk for immune deficiency syndrome. Similarly, thinking about this as we did with cancer panels in terms of what are some of the benefits to patients, really one of the sort of primary sort of goals in someone who has one of these rare syndromes really is to prevent infection, because infections can be life-threatening. So there's a number of different lifestyle modifications and behaviors that may be really important for those individuals, but sometimes there are other therapies that may be considered for some of the more severe diseases. So things like enzyme replacement therapy, bone marrow stem cell transplant, lung transplant, depending on the infection or risks, as well as other management recommendations, may come into play for some of these more rare syndromes. So not just looking at prevention of infection, but other treatment areas. Just using, again, another example, the JAK2 gene is one that's commonly on a number of immunodeficiency test panels. And clinically significant variants in this gene are associated with certain blood disorders. So there's one particular gene mutation that you see listed here, the C1849G to T, that's seen in a large percentage of people with polycythemia vera. And this particular condition is inherited dominantly. So in many cases, we see a positive family history or an affected parent, maybe affected grandparent, and other relatives as well. Individuals who have this condition identified, if they haven't already seen a hematologist, they certainly should be. That's one of the main recommendations. And there may be specific guidelines for medical management that are really specific to each case for this particular gene. But again, just a common example that may come up on this type of testing. So again, those are the two kind of main test areas I wanted to cover. I want to go a little bit into some of the other three tests, but again, I've got some slides included here that I won't cover today, but can share if needed. So one of the other tests is genetic testing for thyroid disorders. In terms of really who should get tested for these thyroid gene panels, they tend to cover sort of a large area of phenotypes. And so when you have a patient who presents to you with a history of congenital hypothyroidism, that may be an indication for thyroid genetic testing. A history of thyroid hormone resistance, symptoms like goiter, hypothyroidism, or hyperthyroidism. Personal family history of thyroid cancer, of course. Some of these testing panels do have some of the genes that are associated with inherited cancer predisposition, particularly pertaining to thyroid cancer. So when we see an early onset thyroid cancer, that may be an indication for genetic testing using one of these panels. And of course, any personal or family member who has a known thyroid disease that's associated with a positive genetic test and a family member would be an indication for genetic testing using one of these panels. Moving right into adult neurology, genetic testing for adult onset Parkinson's disease and a number of the dementias. This is an area where, there's quite a few indications for genetic testing. And again, using that same sort of idea that we talked about with cancer genetic testing and looking at, let's say, Alzheimer's disease, the vast majority of people who have a diagnosis of Alzheimer's disease do not test positive on these genetic testing panels. Most occurrences of Alzheimer's disease occur sporadically or may be familial due to some of these common variants that we see more frequently in the population, such as ApoE, E4 allele. That would be an example there. When we talk about some of these genetic testing panels, really what we're looking at more are these really, really rare genes that may be causative of very early onset Alzheimer's disease, where we'll see a significant number of family members affected by Alzheimer's disease or dementia, if their diagnosis wasn't fully sort of characterized. So just with that, I just wanted to provide a little bit of background information there, but in terms of who should get tested for some of these panels for adult neurology, this is sort of a list of some of the things we think about. So of course, the diagnosis of frontotemporal dementia, there's a handful of genes that are associated with inherited risks for that particular condition. Early onset Alzheimer's disease, we may think about genetic testing earlier than 60. Alzheimer's disease in a number of family members, at least 2 individuals on the same side of the family. And again, most individuals who fit into this category still will test negative. They certainly are people who raise our suspicion for having an inherited predisposition syndrome. Similarly with Parkinson's disease, anytime we see an individual with Parkinson's disease occurring under age 40, that's an automatic recommendation for genetic testing. Parkinson's disease in Ashkenazi Jewish descent is also an indication for genetic testing. There's one particular gene variant that we see a little bit more frequently in that background that's increasing risk for Parkinson's disease. And similarly, if we see someone in more than one individual in a family with Parkinson's disease or Parkinsonism, that's another indication to consider genetic testing. So, again, hopefully you're noticing sort of a kind of a theme here, really age of onset, significance of family history, and then rare diagnoses like frontotemporal dementia and things like that are kind of the things we think about in terms of candidates for genetic testing. Last but certainly not least, I just want to cover a little bit about the final test offering, which covers diabetes and obesity. We see a lot of I would say interesting test orders for this, for these types of panels as well. And I think that's just because the diagnosis of type 1 and type 2 diabetes is so prevalent. And we see a number of people who have family histories, for example, of type 2 diabetes. And so the first thought is, could there be some sort of genetic predisposition? Most of those instances are actually polygenic or familial, meaning they're due to a number of these kind of high frequency, low impact genetic variants that may be shared among a family, not so much due to single gene variants that are often the focus of genetic testing, such as these panels that we're talking about today. Really, the types of diabetes that fit more into that monogenic setting are some of the ones that you see here. Some syndromes where we see diabetes as well as other medical issues are a very, very rare occurrence, but due to single gene conditions. And I think the one that we think about the most in our field in terms of a monogenic cause of diabetes is MODY, which is a form of diabetes that occurs, is diagnosed younger in life, and can sometimes be misdiagnosed as type 1 or type 2 diabetes. And so that's a frequent indication for genetic testing, is if there's a suspicion that someone may have this monogenic form of diabetes called MODY, and may have been misdiagnosed with another form of diabetes. In terms of who we think about being good candidates for genetic testing for a diabetes and obesity panel, Nice list here, but really, what we think about the most, again, early onset. So history of non-insulin resistant diabetes under age 30, personal and family history at any age. Again, family history of someone who's been diagnosed young in life, again, with non-insulin resistant diabetes. Moving over to the sort of obesity side of the genetic testing panel, someone who's had very early onset diagnosis of obesity is someone who should be considered for genetic testing. There are a large number of genes out there that are oftentimes on these panels that can cause very early onset obesity. Most of those are inherited recessively, and we may not see a family history. So if we have one child who has that early onset obesity that doesn't quite fit in the context of their family, meaning no other family members with obesity, that would be a fast indication to consider genetic testing. And, again, you'll see some of the known syndromes listed here. Obviously, if there's a personal family history of a diagnosis of one of these conditions, such as MODY, Bardet-Biedl is one of the obesity syndromes that I was just referencing a moment ago. Any of these sorts of conditions obviously would be a reason for that individual to consider genetic testing if those are present in their family members. So just to sort of summarize, and again, we've talked about this as I've gone through the various test offerings, but again, just to sort of bring about some of the main points that I want to drive home here really is that the vast majority of people who are offered genetic testing don't have genetic conditions. Again, our goal is really to find those rare gene findings, because the screening recommendations and medical management can be so different compared to the general population. So even though these genetic conditions in general are relatively uncommon, we really want to be able to identify them, which is why genetic testing is offered in the first place. For the vast majority of these types of testing panels, really kind of thinking about this phrase of rare, early, and then with or without family history, these are really the sort of the three main areas that we use to assess someone in terms of whether they might be good candidates for genetic testing. And, of course, an obvious benefit to genetic testing is family members having access to that information and testing. When there's a diagnosis made and there's a genetic finding, that's an automatic test that a family member has access to find out if that's something that they may have risk for or not. And of course, we always feel having access to a genetic counselor and geneticist is really important in terms of identifying, who might be the best candidates for testing, who might need additional testing, and helping to interpret genetic findings and what those screening recommendations may be based on those results is, of course, important. I mentioned early on, in terms of our educational materials that we've got available for you guys. These, obviously, I don't expect you guys to be able to read these or see them, but just to point out, we've taken the slides that I've kind of shared today. We sort of have a similar 2-page flyer available for each one of these areas. And so those are educational materials that we have available for providers who are considering ordering these types of genetic tests. And it really covers some of that information we've talked about today in terms of what are the benefits to patients, who might be good candidates for testing, what do those results change for that individual if they have a positive result. And all of that information, like I said, is available for these tests. This is just a slide talking a little bit about one of our more common workflows for post-test genetic counseling support. And so if you sort of think about, the sort of stepwise process where genetic testing is ordered, the lab completes the test, oftentimes that's the point where we come into play for a post-test review letter, meaning our clinicians, genetic counselors, will review those results and medical records and then generate a clinical summary letter that's then shared back to the lab, who would then take that information alongside the test result and share it with the physician and sometimes patient as well. We do have support options both for patients and physicians. And so at that time, when a provider or patient receives our consultation or our clinical summary letter, there's information at the very top of those letters where a provider or a patient can reach out to us directly for a consultation. And so and that's available through phone support, but also available through one of our other mechanisms like a chat line. So that's just a resource that's available at the post-test review letter part. And then, just finally, a couple more resources that are available. Like I said earlier, our clinician platform is really, available to all providers. It doesn't have to be the ordering provider of a genetic test, and I think that's a really important point to let people know about, because I think a lot of providers say, well, I didn't order this test, and so I don't know that I can use this resource. Definitely, as long as that letter with the information pertaining to this particular patient is included, any provider has access to reach out to us by using that clinical summary letter. And one of the features that we use relatively frequently is accessing a number of health records from health exchanges. And so that is something we take into account when we're writing our clinical summary letters, is looking not just at the test result itself, but any available medical records to help provide a more sort of comprehensive assessment or interpretation of that test result. We also regularly track variants that have been reported for any classification changes, and have a system in place to report back any changes to any variants reported. So just a couple of other kind of features that are available through our service that we provide. And with that, I will open it up for questions if anybody has questions they'd like to review.
Hi, this is Louis Grabowski with PreCheck. How are you?
Hey, good. How are you?
So I'm great. I'm great. These all look great. Like the obesity, all of the stuff you talked to. What about insurance reimbursement for these things?
Yeah, I mentioned early on when I was talking about the cancer panels, insurance reimbursement really, the more someone has these sort of indications, so like if you go back to our slides where it's like who should get tested, for example, the more of those features someone has, the more likely they will be to get insurance coverage for these types of tests. Now, some tests are reimbursed more readily than others, and some insurance companies cover testing more readily than others. So there's always caveats there. But certainly all of these tests are reimbursable by insurance, particularly, if someone has, a number of these indications for testing.
Okay, so to pre-qualify, they would run some kind of advanced blood work or something to look for markers and then run the genetic screen, or because, okay, so I come from a world, my previous job at another lab, we did PGX and we did CGX. Our CGX was a straight out inherited cancer screen, period. It would look for, ovarian, and men, obviously, the other types of men. We even had a panel that wasn't all that accurate, but it was for, throat and mouth cancer, which is all basically related to the virus. So, with the CGX, when we wouldn't run any tests unless we had pre-authorization. We would get the rec form, the sample, we would run. If we didn't get a pre-authorization, there was no reason to run the test. A lot of other labs out there were running tests and billing patients and doing dumb things, right? So we didn't do that, but we found out that the only way really to get a CGX test, other than if it was a Medicare patient, or somebody under Medicaid disability, like, they were whatever, anyway, extenuating circumstances, was if they had previous history, family history, obviously, of cancer. But these other specialty panels that you're talking about now, they're relatively new. I was just wondering, because this is something that's fantastic and a nice feather in your cap when you're going into a new office, right? To set yourself apart as a lab. You're not just doing blood and tox, you're doing these cool things. And so I was just wondering what percentage, can we get, if you submit 10 patients, are 6 going to get pre-approved, or is it some free work that has to be done in order for this panel to be approved, like blood work or something like that? If you could answer that, that would be great. Thank you so much.
Yeah, and I'm probably not going to be able to answer that question because
I
I
can
don't.
answer that.
Yeah, I was
Heather.
going to say one of you guys would be able to answer it, I'm sure.
So Louise, BigCam is a revenue cycle management company, and we've been into revenue cycle since 19 years now. And that's when, I think 3 years ago, we decided to open our lab, which is St. Jude Labs, when we collaborated with PreCheck. So to answer your question straight out, if you submit 10 patients, regardless of the insurances, we submitted about 7 patients recently, and we got approved on 4 for immunopanel, for the metabolic panel, the diabetes
Okay.
panel,
All right. That
the
makes
last one
sense.
that Heather showed. Yeah,
Yeah.
and most of those were, a couple of those were Medicare. Medicare, like you said, not a problem. But I think 2 or 3 of those were United Healthcare plans. I've seen a couple of Blue Cross Blue Shield plans go through. So what you need to just tell the doctor that you need to submit the SOAP notes and the medical records, and the
Right.
medical records need to indicate that this patient has had a history of this problem. There has been a hereditary, flow of this kind of a deficiency or these kind of symptoms. All that, if that's included in the SOAP notes, I've seen that 8 out of 10 times the prior authorization gets approved. The SOAP notes have to be strong medical
Okay.
records.
All right. And that's understandable, that even for PGX, because I've been doing it for so long, that back when like 1 out of 10 PGX tests, got approved by public, private insurance, you had to you almost need to send their waist size and their shoe size, and you know what I mean? I'm going overboard, but basically, what's the size of their underwear before they would approve it? And those days are gone now. Down here in Florida, Medicare, the payer section here is like 90, Medicare wants PGX done on every patient, period. Yeah. They're wasting millions and millions of dollars, we know, on the wrong medications. But so when we submit these patients, do we get authorization before we run the test?
Yes.
Okay.
Yes.
Right.
So what we normally do is we tell our providers, once the patient comes in, you assess the patient, what the symptoms are, and okay, this is a candidate for a genetic test. So that's when you submit the requisition form and you give us the patient details, everything, so we can apply for prior authorization and the SOAP notes, the medical records. And then once it gets approved, it takes typically 5 to 6 working days. Once the approval comes, then the patient has to be called in again to collect the sample. So it's like 2 visits.
Got it. Got it.
Yeah.
Okay. And that's okay. The doctor doesn't mind. They're billing for the visit again.
Yeah, they're billing for the visit again. So,
Yep.
and the patient doesn't mind because you're getting such an advanced testing done and the insurance is covering it. So the patient doesn't mind that either.
Okay. Thank you very much. This was very, very helpful. One last thing. Can somebody from this group send me this recorded presentation? Because this is going to be great. A lot of the doctors I invited are like, Louis, come on, bro, you crazy in the middle of the day I can't sit there, but there's a lot that want to hear it, right? So
yeah,
if I can get this recording, this would be fantastic.
Absolutely, Louis. No, I appreciate your input.
Thank you. Thank you, Doctor.
Recording, not only will this recording be free, we're also offering free genetic counseling services for both providers and their patients.
Awesome.
So that's something that you can also emphasize with your respective clients as well, Louis. Thank you so much.
Thank you, guys. Thank you very much.
Hey, Louis, I want to jump in. This is Frank. And thank you so much for the presentation. I wasn't aware, just going back to that first slide that you showed, that the people with hereditary cancer only represents 5 to 10% of that pie chart, whereas 80% is from environmental and lifestyle. And I think, when I'm talking to all the medical reps on the phone and you're talking to the doctors, that totally shifted my thinking. Whereas if you educate the doctors to that pie chart, it doesn't really matter if they get scrubbed and they don't get approved for insurance. People should get tested because of that pie chart itself, that 80% of the people that get cancer is because of environmental and lifestyle. Whereas, you know, we're right now getting approved on only 5 to 10% of the population that's getting tested because one of their family members has had cancer.
Mm-hmm. Mm-hmm.
So that to me, I think is a very strong argument to the doctor when you go in there based on that pie chart, which I wasn't even aware.
Mm-hmm.
Do we have a self-pay pricing for these panels? That would be very helpful too, because some of my doctors, their patients are rather well-to-do. They wouldn't mind putting out money to find out if they're at risk for one of these
Yeah,
things.
we do.
Mm-hmm.
Okay.
Francis Pittoloni has that for you.
Okay,
you can give
beautiful.
him a call and he can go over that, because we do have a lot of cash pay practices,
Mm-hmm.
Yeah, there's a bunch. I mean, I have
wellness centers, things like that.
I have 5 or 6 concierge medicine docs that they don't even take insurance. You pay them. I do it myself. I pay a monthly fee, me and my wife, to our primary, because we love her, and we, I can send her a text and get a refill. I don't have to wait. It's kind of cool. So thank you for that.
Yeah, and I sort of brought that up early on too. Like in our field, you know, we've seen lots and lots of changes in genetic testing over the years, and you know, it used to be only a very small number of people were even offered genetic testing or allowed to get genetic testing. And it really has changed a lot. And we see a number of people just sort of proactively wanting that information, and there's, you know, there's an argument for it because not everyone fits into those risk factors. Some people say they're adopted, they don't know their family history. Some people have small families. Some people are lucky, and even though they have high risk for cancer, they don't get it. And so, you know, there are certainly gaps in utilizing the sort of criteria for genetic testing. And that's why I always point that out. Unfortunately, insurance companies use a lot of that criteria because they're covering a select subset of people who are higher risk. But we see tons of people come through, at least through our service, you know, proactively wanting genetic testing and wanting to pay for it if their insurance won't. So it's nice to have that as an option.
Right. And insurances wise, I've even seen a trend in the past couple of years. Insurance, especially Medicaids, are now promoting. They're dropping the regulations on their prior authorizations. Like Louis said earlier, it was like a 20-page intake form, literally, for hereditary cancers, and it was very complicated. They're making it simpler now, especially Medi-Cal, and a couple of other Medicaids I'm forgetting off the top of my head, but it's the way of the future. They all know that this is the specialized testing that'll be needed, and especially with gene therapy coming in now. So that's my only question. You remember, Heather, when we were talking last, I was like, once you diagnose, say, for example, you diagnose SCID, then what about the treatment options? I mean, you did mention stem cells, bone marrow, all of that. But of course, for a primary care physician, getting to know those treatment options or referring to a specialist, I think those are the options, but would love to go that route and learn those.
Yeah. And I think a lot of those, they are up and coming, but not frequent enough yet, unfortunately. But there are a number of genetic diseases where there are more disease or gene specific treatments available that weren't available 5 or 10 years ago. And so, you know, when we were talking earlier this week, I was saying, you know, for example, when a genetic condition is diagnosed, usually that patient moves maybe away from primary care a little bit and sees a geneticist or, you know, some other specialist, because they're the ones who, you know, are more sort of attuned to what therapies may be up and coming, or their clinical trials, for example. And again, I think it's certainly becoming more available. I think, unfortunately, it's not available for every genetic condition at this point, but there's still hope. There's still active research, and that's where these, you know, referrals to specialists and clinical trials and things like that are also important.
Right.
Yeah.
Definitely, I agree.
You know, and I mean, even conditions like cystic fibrosis, for example, you know, cystic fibrosis, back when I was starting as a genetic counselor, there were no real treatments available and life expectancy was significantly reduced. And now, you know, there's some sort of life extending treatment available for certain, and not for everyone with cystic fibrosis. Sometimes it's certain genetic mutations that are more amenable to treatments. But that's where the genetic testing obviously becomes really important.
Right.
And early diagnosis also.
Early diagnosis, yeah.
Yep. Yep.
I have one question. When you're doing these larger NGS panels, are they submitted on a single CPT panel code, or is it a per gene CPT code?
It's a bunch of codes. It's not a single code. It's a bunch of codes. Madhura, can you answer that? Madhura is from our coding team. When you were submitting the claims for immunology, for example,
Yeah.
was that like a set of 5
Yeah.
or 6 codes?
So yeah, it's like mostly per gene, and some genes are clubbed in some CPTs. So most of the time it's per gene. Yeah.
Okay, most
So
of the
there
time.
are a bunch of codes, like a set of codes we have to submit for depending on the panel, like how many genes are there. Like there are 64 genes, then we have to submit accordingly. So it's not like there will be 64 CPT codes. Some genes will get clubbed in one particular CPT, but likewise we have to submit at least 10 to 12 CPT codes depending on the genes.
Did that answer your question, Sam?
Yes. So I know in the
Okay.
past, it's been a challenge on the prior authorization side with the CPTs, especially if there's multiple within a panel. I know there's been some pushback on the payers because I think they're wanting more of a single CPT code. I thought they were.
Yeah, so it's more of a clubbing. Like Madhura said, almost 64 gene panel, at least 10 to 12 CPTs in that panel. So, yeah.
Thank you.
Come.
Any other questions? Heather, thank you again. Heather, you did a fantastic job explaining it.
Yeah.
I
A
do
lot
like
of information.
I do like the shout out to Modi. I found that interesting. I'm not sure if you're aware that is the Prime Minister of India, so I'm glad he was not on the call when you referred to Modi, but that was something I learned. That was something new that I never knew before.
Yeah,
Yeah.
funny.
Yeah.
Yeah, and let us know. I mean, I know you've recorded this and you've got access to the slides, but if there's other resources that you guys want from us, we're happy to help.
Thank you.
Definitely.
Thank you.
Thank you so much. And thanks, everybody,
Thank you, everybody.
Thank you.
for your time.
Thank you.
Thank you so
Thank
much.
you.
Thank you. Thank you.
Have a great day.
Take care, guys. Bye.
Mhm.
Absolutely. Bye.